on, right? Duminda?
Yes, I'm here.
Okay. So if you know me, I'm Professor Kudagamana, so president of PeMSAA, and I would like to welcome all of you for the first of the evening talks organized by the PeMSAA. So this lecture series is a part of our activities aimed at producing confident, competent doctor who has achieved the full potential, who loves the faculty. Okay. So we would like to know your requirements, and please liaise with Dr. Duminda Asaratna or Dr. Buddhika Dissanayake for your future requirements. So the PeMSAA, as you know, is always to help you, and please make use of these activities to help your achievements in the time to come. So I must thank Duminda and Buddhika for liaising with Sisira so that you made this event a reality. So, and in addition to that, I would like to ask all of you to apply for associate membership and join PeMSAA so that we can continue to help you, and you also can be part of helping your junior colleagues with time to come. So with that, let me invite Duminda to introduce the speaker, Dr. Neranjan Dissanayake. Over to you, Duminda.
Right. Thank you, Tushar. Good evening to all. It's my great pleasure and privilege to introduce Dr. Neranjan Dissanayake, who's my colleague and friend. So I'm not going to do a full formal introduction. So you can see that in the screen that he has a very long professional record. Neranjan is a well-recognized and well-respected academic and a clinician. So he's the consultant respiratory physician attached to Ratnapura Teaching Hospital. Before going to Ratnapura, he had worked at Badulla, and before that Nuwara. So he's a very experienced respiratory physician, and he's going to talk about a respiratory condition, acute breathlessness. Apart from that, just a little bit about Neranjan's faculty career. He has been a very illustrious student in the medical faculty. He has been a good all-rounder. He has done his academic part very well. He has had honors and distinctions in most of his, like all his exams. He had honors, and then not only that, he had a lot of other talents. He's a singer. We just few weeks back we had our PeMSAA inauguration night, and he has sung a very nice song of Vayo group. And during his faculty time also, he has been a writer, singer, and also he has involved in drama. So he has been a very multi-talented person. You might know that Neranjan is married to Dr. Nilanti Dissanayake, our consultant microbiologist who is in the Department of Microbiology. And going through his records, I found that Neranjan also had a distinction in microbiology. So I'm sure that helps that in his practice as well as at home. So with that, I would invite Neranjan to take it off from here. Over to Neranjan.
Okay. Right. Thank you very much, Duminda, and I hope that we can see the screen now. Is it okay, the screen?
Yeah,
can you see
you?
screen?
We can see the screen.
Yeah, we can see.
Oh, right. Okay, right. No, where, if anything can go more wrong, I had many things going on during this last half an hour. My computer crashed, and computer crashed. The internet connection was not working as it should be. And I don't know what happened, but anyway, finally, thanks to my son, I was able to come out with this presentation to you. So this is not the presentation that I made, but it is similar to what I was planning to talk to you. But hopefully, I think it will be very useful to you. And thank you very much, Duminder, for your kind introduction. And it was indeed a pleasure, working with you as a colleague and in the council as well as in the specialty board. And thank you, Professor Kudagamana, for leading us. And the council as well, Cicera for connect all the things that she has done. So without much delay, I will start my presentation. And this we wanted to do in a casual sense. Hence, I'm in a casual mode as well. So if any one of you have any questions, please be free to inbox the questions, and Duminder will coordinate the questions. But if you want to disturb me and ask any question, please be free to do that as well at the same time, because I will not be disturbed. We are here to help you. This is a very informal lecture. That is the way it should be done, these evening lectures. And hopefully we will be able to have a very good discussion rather than a normal lecture that we have in a lecture hall. That is the main aim of this evening talks. So I'm fortunate to be in the 95-96 batch, and I have some illustrious people attached to the Faculty of Medicine. Professor Taraka Dasanayake is one. Dr. Sisira Dharmaratna is another one, and Tilanka is there in the pharmacology department. And as Duminder pointed out, there is one batchmate in Department of Microbiology who is more than a batchmate to me. So why I used this topic was that, why did I thought of discussing with you this topic is that, right, how can I go for the next slide? Just I want to go to the next slide. Okay. How can you go to the next slide? No. All right. Okay. Good. So now the reason that I selected the breathlessness as the first topic to discuss with you is that basically it is one of the most commonest presentations that you will get in your day-to-day practice when you become a house officer, as well as a clinician in your later life. Whatever your specialty is, be it pediatrics, be it medicine, be it surgery, and even gyn and obs, you might get patients with breathlessness coming to you. And we have to have a sound understanding of what to do so that we can do the needful for our patients without any significant harmful effects to them. So when you look at the definition of breathlessness, it is basically an uncomfortable feeling. That's the most important aspect that we have to take from this definition. Even though there are a lot of definitions of breathlessness, I don't think that we have to define breathlessness. You feel breathlessness, and when you see breathlessness, you will be able to identify breathlessness very easily. It is one of the few things that can become a symptom as well as a sign. And sometimes the patients will come to you and tell you that the patient is breathless, but you might not see that there is any subjective. But at the same time, sometimes you might see that the patient is breathless and tachypneic, but the patient might not complain of breathlessness, especially in conditions like acidosis, where there are a lot of things going on and the patient's major complaint is not the breathlessness, but you will see that the patient is tachypneic and breathless. So this is the most important thing. So it is a very uncomfortable feeling, whatever the underlying lesion is, underlying cause is. And one of our major functions as a healer is to make the patient comfortable and prevent unnecessary comorbidities and mortalities. Right. So just a brief look at the mechanism of breathlessness. Breathlessness is basically sensed by the brain, the cortex, right? So, and we have the brain stem here, and we know that that is the respiratory center that you have in the brain stem. So basically the uncomfortable feeling of breathlessness, for whatever the reason, will be felt by the cortex of a person, right? And you can actually make yourself breathless by voluntarily hyperventilating yourself. But most of the causes of breathlessness are either physiological or psychological, and there are some social aspects of breathlessness as well. So if you look at the anxiety or the emotional part of breathlessness, almost you will understand that physiological, social, psychological, and social aspect of breathlessness are tied together in a one group. So you will have many examples to see how you become breathless. One feeling is that when you feel anxious, so without any physiological abnormality, you can feel breathlessness because when you are anxious, and it will affect the respiratory center as well as it will affect the cortical centers, and you will feel breathless. But we are not worried about that aspect. We are worried about the physiological aspects of the breathlessness at the moment. So if you look at these two graphs, which is taken from the Davidson's book, if you look at the left side of this graph or left of this picture, you will beautifully see how breathlessness occur due to the most of the commonest causes of respiratory diseases. Now, for example, we have this airway. I think that you... Hello? Yeah. Yeah, so you can see the airways nicely, and you can see that the airways are narrowed here. And when we know that in your physics days, you can remember that when the airways are narrowed, especially if you narrow the airway by half, the resistance to the flow of the airway will increase by about 8 times. Hence, the work of breathing will increase. So, when you have that aspect, when the airways are narrowed, we call obstructive airway disease, which should happen mainly in bronchial asthma as well as COPD, and to a certain extent in diseases like bronchiectasis. What happens is the resistance to flow increases, and then because of that, you will have increased workload, mechanical workload to the respiratory muscles, mainly the intercostal muscles as well as the diaphragm. And when you have stimulation of these muscles, the spindle cells of these muscles, there are actually afferents going into the respiratory center, which stimulates the respiratory center to increase the breathing effort as well as the rate of breathing, and then it will be sensed by the cortex as breathlessness. So that is one way, that is obstructive airway disease causing shortness of breath. And as you know, when you have obstructive airway disease, when there is a significant obstruction, especially in conditions like COPD, there is a rise of carbon dioxide in your body. That's hypercapnia. So when your carbon dioxide washout is reduced, not only in COPD, in severe pneumothorax, when large pleural effusions happen, Guillain-Barré syndrome causing muscle paralysis, most of these conditions will impair the ventilatory effort of your body, and hence, mainly the carbon dioxide levels will rise. As you know, when the carbon dioxide level goes up, it will cause increasing of pH, so reducing of pH, where the pH will be dropped, and this drop of pH will be sensed by the central chemoreceptor through the CSF pH drop. And this is a marked stimulator of the respiratory drive, right? So when you have this, the carbon dioxide, increasing carbon dioxide for whatever the reason, reducing the pH of the blood, and then in the CSF, you can also feel breathless, right? So those are the two ways that we have breathlessness in these patients. Now, at the same time, that is the ventilatory failure as well as in obstructive airway disease. Now, sometimes you can have conditions where the normal parenchyma of the lung is replaced by fibrous tissue. Right? So the normal parenchyma, we know that the lung parenchyma is a very soft and elastic structure where you have a very low compliance. That means the lung is nicely expanded with the minimum amount of pressure and then constricted. But what happens in interstitial lung diseases and pulmonary fibrosis is that this nice lung tissue is replaced by the compliant lung tissue is replaced by fibrous tissue, and when that happens, to expand this lung further, you need to have more power in your muscles. For example, the best example is you can blow a nice balloon which has a good compliance easily, but when you blow a very hard balloon, then it will be very difficult to you to blow it in. So that, like that, when you have pulmonary fibrosis, the lung is very stiff, and to expand that lung, you also need increasing amount of power in the respiratory muscles. And hence, again, this is another cause of breathlessness. So you have the obstructive airway disease causing increased impedance or resistance, which in case secondary to that, you can have an increased mechanical load to the muscle, causing breathlessness. At the same time, it also increases the carbon dioxide, stimulates the central chemoreceptors, and then causes breathlessness. And in pulmonary fibrosis, one way of having increased breathlessness is the increased stiffness of the lung, causing increased mechanical load to the muscles of the respiratory muscles, and hence you can feel breathlessness. And the other way of having breathlessness in pulmonary fibrosis is that when you have pulmonary fibrosis, the interstitial space of the lung, which is the most important part in the oxygenation of the lung, where from the alveolus to the blood, it nicely flows, the oxygen nicely flows without any disruption in a normal person. But when the interstitial space of the lung, that is the area between the basement membrane of the alveolus as well as the basement membrane of the pulmonary capillary, it's a very, very thin area. And when the fibrosic tissue replaces that area, you can have disruptions to the flow of oxygen. Hence, you can become hypoxemic, especially early in the status. When you walk out, you can become hypoxemic. But in the later stages, even at rest, you can become hypoxemic. So these interstitial lung diseases, be it acute or chronic, can cause significant amount of hypoxemia other than causing stiffness of the lung. One of the best examples that I can give you is the current COVID pneumonia. That is spreading like wildfire in Sri Lanka at the moment, unfortunately. What happens is when you have pneumonia, that is a viral infection coming into the alveolar sites, and then these alveolar sites are destroyed, and there is an inflammatory reaction on top of that. Both the viremia as well as the resulting inflammatory response will cause a significant amount of damage to the epithelia, as well as accumulations of fluid and cells in the interstitial spaces, disrupting the oxygenation of the lung, oxygenation of the body. So whether it's an acute interstitial damage or a chronic interstitial damage, we can have a stiff lung, which is very difficult to expand, and at the same time, we can have a lung which doesn't oxygenate the blood as it should be. And both these causes will cause dyspnea in a patient with interstitial involvement of the lung. So we can have this hypoxic drive, which is sensed by the carotid bodies in our peripheral chemoreceptors, and then through the glossopharyngeal, it will be conducted to the brain stem, right? So that is one aspect that we have to think about. So we have the obstructive airway disease, we have the pulmonary fibrosis and the interstitial lung diseases causing shortness of breath. And another important aspect that is a cause of shortness of breath, which I want to discuss, is the pulmonary embolus. Now what happens is, now this lung has various afferent receptors in the lung. There are the slowly adaptive receptors as well as the rapidly active receptors of the lung, and they have what we call C fibers, which innervates the bronchial vessels as well as the interstitial spaces of the lung. So hence when this happens, what happens is when you have an acute embolus, that is a blood clot going into the lung and clogging the pulmonary arteries, the mechanical stimulation will be sensed by these, mainly by the pulmonary C receptors as well as the rapidly receptors, and it will be sensed to the brainstem in these patients. And at the same time, when the pulmonary artery is clogged due to a vessel, what will happen? You will not have oxygenated blood going outside from this vessel. Hence, there will be ventilation. That means the patient will be breathing out in and out normally, but the blood supply, the perfusion, is not there in that segment of the lung. Hence, there will be a perfusion ventilatory perfusion mismatch, causing hypoxemia, because the blood is not going in through that ventilated region. Hence, whatever the blood going in will not be oxygenated. So whatever the, what you call this, blood going, the air coming in will not be utilized properly. Hence, when you have a pulmonary embolism, you will be hypoxemic as well, depending on the size of the pulmonary embolism. Now, that is also important in the current COVID stages, because we know, especially in patients with COVID, they have a higher tendency for having pulmonary or other thrombotic events as well. So whatever the reason, when you have a pulmonary embolus, due to two reasons, because of the hypoxemia, and the second thing is when the patient is having a mechanical receptor stimulus, they can cause shortness of breath and a pleuritic chest pain. So the importance of understanding these basics in the causes of shortness of breath is that your treatment modalities will be dependent according to those primary pathological factors, and we have to correct the factor depending on that. For example, a COPD patient, that is obstructive airway disease, the main cause of breathlessness and hypoxemia and increased carbon dioxide is narrowing of the airway. Hence, in that instance, nebulization with salbutamol will work. But for a pulmonary embolus patient, however dyspneic he is or not, if we nebulize, that will not work, and that might do more harm, causing patients to have arrhythmias because of the salbutamol or beta stimulant effects. So that is why, as doctors, medical students, and medical practitioners, we have to identify and understand the basic pathophysiological mechanisms when we think about treating patients with these diseases. And another important aspect that I would like to discuss is about the pneumothorax, which I will be showing you some photographs later, where the lung is suddenly collapsed when the air is filled in the pleural cavity. And here also the patient will become suddenly dyspneic with a pleuritic type of a chest pain, and then the patient will be hypoxemic. Hence, you can now understand how this patient will behave, because of the cause of breathlessness is mainly because hypoxemia, that is the first thing, and because the lung is collapsed, the rapidly acting receptors will be activated, and that will give us a sensation through the afferent fibers to the brain stem, and hence the patient will be dyspneic in this instance. So we can understand these, and later on when the patient will become, then the ventilatory failure happens, the carbon dioxide level will go up, and hence that will also stimulate the respiratory center. So when we know the causes of these pathophysiological changes, I think then we can treat the patients more appropriately, right? So in summary, I think we have to understand that whatever the cause of breathlessness is, most of the time, these three are the main causes, out of which I would like to highlight the third cause, because we have to identify hypoxemia and hypercapnia and acidosis as early as possible, because they are the most life-threatening conditions that we have to correct very, very rapidly, rather than waiting until we come into a diagnosis. So I would like to stress that even though in this slide it is mentioned as the third cause of the pathophysiological causes of dyspnea, hypoxemia stimulating the peripheral chemoreceptors, hypercapnia stimulating the central chemoreceptors, and acidosis stimulating the peripheral chemoreceptors are the most important things that we have to correct, identify first, and correct whatever the underlying pathophysiological mechanism, if we want to save the life. There you can't think about the underlying cause. We have to correct the underlying pathophysiology of hypoxemia, hypercapnia, and acidosis as early as possible, or else the patient will deteriorate within the next 5 to 10 minutes or within the next 30 minutes, and you will have a arrested patient very, very quickly. Right? But we have to think about the increasing mechanical load, which is easy to remember, and that, as I discussed, and then the stimulating of intrapulmonary sensory nerve. So these are the main pathophysiological features that underlie dyspnea in most of the patients. Right? Now, this is the type of patients that you will have. I had some beautiful local pictures, but I will show it to you in a different time. So these patients are dyspneic. Now, for the patient, I think it is very important as treating doctors and medical professionals to understand whatever we do for the patient is not important unless you relieve the patient's discomfort and dyspnea. You can have a beautiful diagnosis, okay, but if the patient's distressed and the patient's distress is not alleviated, it is the patient will not appreciate what we do. And at the same time, whatever we do, we have to do it very quickly and rapidly and appropriately, not increasing the severity of the disease and making the patient better as early as possible. So when we now looked at the definitions, we looked at the theory of dyspnea, we understand the basic pathophysiological aspects of dyspnea, but mark my word, the first day that you come to the medical ward or a surgical ward, and when you are presented with a patient with dyspnea, and the nurse says, "Doctor, menna me patient husma ganna amaruyi," you might just feel very, very, very anxious. That happened to me. I'm sure that that has happened to many, many other people as well. I can still remember my second day of internship with a clinician that I really love and admire, Dr. Mangaleshwaran. And we had a nice senior house officer called Dr. Ranjit, and he's currently in Australia. He's a psychiatrist now. So within that day, I have given him about 15 phone calls. Okay, right? So it happens, right? So it happens. So, but we have to be prepared for what we do, right? So what can we do to a patient with breathlessness? Do we have to have a structured effort when we are managing patients with breathlessness, right? Thinking about some causes will be very, very important. Some of these causes I told you: pneumothorax, pulmonary embolism, foreign body. Immediately you have to intervene and treat. And one of the most important things that is not there in the slide is anaphylaxis, right? Anaphylaxis, if not identified properly, can kill your patients within the 15 to 20 minutes maximum, right? And it is a completely reversible cause of death. Hence, I think as even first year, final year medical students, you should know exactly what to do in a patient with anaphylaxis, and you should understand what to do, and you should understand the underlying physiological basis of a patient with anaphylaxis, and you should be able to identify a person with anaphylaxis, because anaphylaxis comes out of the blue, right? It comes out of the blue suddenly. 12 o'clock in midnight, sometimes in the night round, you start antibiotic, you get the call at around 10 p.m. they're saying that the patient is bad. You start sometimes a blood transfusion, sometimes an injection, sometimes the patient has been given for dinner, the relatives comes and have given the patient some dinner containing something like manioc or something like that, the patient is allergic, and suddenly the patient will develop these symptoms. So most of the important thing in anaphylaxis is identifying anaphylaxis. So anaphylaxis in dark-skinned people like us is sometimes difficult to identify. One of the features of anaphylaxis is the urticarial rash and itching. And then another feature of anaphylaxis is the wheezing and the shortness of breath and the chest tightness that develops with anaphylaxis, because there will be a huge histamine surge, bradykinin surge, and these chemicals will stimulate your bronchial epithelia, and it will make them constricted, and at the same time these will be stimulating your bronchial C fibers as well, and then you will feel a feeling of breathlessness as well. And then they will be vasodilating, these chemicals. You will have a chemical bomb exploding inside of you, and this vasodilation will cause a sudden diameter increase of the vessels, and then you will have hypotension with a wide pulse pressure, right? So if you have to identify these patients might come with an itchy rash. They will complain of a chest discomfort with wheezing. The third thing that you have to look is they will have a postural drop or they will have a hypertension with a wide pulse pressure and a wound impulse as well. So if you have any of these features in the correct clinical setting, we have to think about the possibility of anaphylaxis. Certainly, when it develops into later stages, you will get this angioedema, swelling around the lips, and sometimes you can get a severe swelling in the neck and the mucosal swelling, and you can get even stridor. The patients will be having difficulty in breathing, and sometimes you might even need a tracheostomy in these patients, emergency tracheostomy. So identifying anaphylaxis is very, very, very important, because the treatment is very, very easy. If you identify that, it is IM adrenaline, and if you are confident and if you have a cardiac monitor, you can give IV adrenaline, but I suggest that not to give unless under SHO cover. Basically, IM adrenaline is 1,000 0.5 milligram IM. I think you have been taught about this as well, but don't forget about it. In children, depending on the age, the dose will differ, but the treatment of choice is not hydrocortisone, not IV Piriton, not nebulization. It is adrenaline, nothing else. You have to give adrenaline. If it is doesn't working, you have to give another adrenaline and monitor the patient closely, right? And the second important thing is, because there's a huge vasodilatation in this patient, the important organs, the vital organs of your body will not be perfused in the appropriate way. Hence, you have to replace fluid as well to keep the perfusion going on. So two main aspects of anaphylaxis is that adrenaline, first thing; second thing, fluids, white cannula and fluids, right? So if you do that correctly, the patients will improve rapidly. But there can be late anaphylaxis coming in after you treat the anaphylaxis. After about 4 or 6 hours, sometimes you can have a late anaphylaxis, especially when the patient has needed multiple epinephrine doses or adrenaline doses, or when the patient has a wide pulse pressure and severe urticaria rash. They tend to have, after the first insult, after you treat that, even after 2 or 3 hours, they can have a recurrent anaphylaxis episode without any trigger. So you have to monitor these patients at least 6 to 8 hours closely, especially in a severe case, right? So anaphylaxis is very important, even though it is not here in the course of dyspnea the causes. I have put it in the other slide, but it's not there. But anyway, it's very important, and I would like to stress the importance of the importance of identifying anaphylaxis and having the ability to treat these patients, because it is a life-threatening condition. Other ones, pneumothorax, pulmonary embolism, foreign body, are also important to identify. And then you can have severe asthma, and then you have lymphatic failure and cardiac failure, and the cardiac causes of shortness of breath. You have the pneumonia coming in about 2 or 3 days, especially in this time of period. We have to be very careful, especially the ones who are at home. Be careful. A small respiratory infection, a small cough within 1 or 2 days can develop into a severe shortness of breath and dyspnea, and you can become hypoxemic within about 2 or 3 days. Be careful about it and think about the symptoms of shortness of breath, especially when you are working and when you are at home also. Even though you might not get shortness of breath when you are at rest, after you go to the toilet or climb one flight of steps, you might be feeling unusually shortness of breath after a small respiratory infection. Be careful. That might be a feature of early interstitial involvement or viral infection or COVID infection as well. And hyperventilation, basically, even though the patient might not complain shortness of breath, these hydrogen ions will stimulate in renal failure and diabetic acidosis, and also, especially in young people, think of poisoning as well. Right. So I will go to the next slide. Right. So how do we assess? Now, thinking about all these underlying causes, thinking about all these mechanisms, I think we have to have a very good plan of approaching a patient with shortness of breath. The most important is to approach the patient with a clear mind, and you have to approach the patient very, very quickly. As medical professionals, our patients' lives will be depending on us. As even house officers, when you go on the first day, from the first day, patients' lives will be depending on what you do or what you don't do. So one of the most important thing is patients who are sick, and when informed and when seen should be approached very quickly. So when you approach the patient, one of the most important things to assess is the level of consciousness. If a patient is responsive and looking at you, most likely, that patient is not that ill than a patient who is not responding, right? The easiest way to know about the consciousness level is the AVPU method. That is, if the patient is alert, that means when you come to the bed, he just look at you, right? So he's alert. He is responding to the surrounding environment. Second one is pain. The patient is not responding, but you have to go and you have to give some pain to the patient so that he will be responding. And the verbal, sorry, second one is verbal, where you make a verbal command. You ask, okay, Samarasinga, Harenda, then he will be waking up. The third is the pain. Even the verbal command doesn't work, and you is unconscious. So the level of unconsciousness will give you an idea how critical the patient is, right? Sometimes the patient is confused, he's putting out the oxygen. That means that the patient is probably in the later stage of consciousness. So you have to approach the patient very quickly. Cyanosis is a very important fact that you have to look in that patient. When you approach a patient, okay, when you go to the patient, the important things that you can see is the level of consciousness, the patient, whether he is conscious or not, according to the AVPU. The second other important thing when you go to the patient is that you will see the respiratory rate of the patient, especially in a breathless patient. So the patient might be tachypneic. The rate might be high or the rate might be low. Right? So even though sometimes the patient might be attached to a saturation probe, and the saturation might show a 97% saturation of the patient, but the patient's respiratory rate is about 25, 26, 30, that you can't be happy about, because he's maintaining that saturation with increasing about ventilation. So that patient needs early intervention, right? So respiratory rate is very important. If a patient is not breathing the normal rate, reduced breathing, especially this can happen in poisoning, in conditions like Guillain-Barré syndrome, in patients like COPD with carbon dioxide narcosis, then the respiratory rate might slightly drop before going into a coma. There we have to be very, very careful about this patient. So when you go to the patient, the consciousness is very important. Look at the respiratory rate and the depth of the patient. For example, the depth is very important when you diagnose acidosis. So you would have seen patients with acidosis where they have, rather than a normal, shallow, rapid breathing, they have rapid, deep breaths coming in and out in an acidotic patient. A young man coming with increasing amount of shortness of breath, acidotic, low level of consciousness, until proven otherwise. Think about diabetic ketoacidosis. Think about acute renal failure with acidosis or poisoning. So depending on that, we can think about the underlying possible etiology. So when you go near the patient, think about the cyanosis, where you can have central cyanosis. There will be a purple rip, where at least you have to have desaturation of about 5 grams per deciliter of hemoglobin, right? And the next important thing is anaphylaxis, signs of anaphylaxis. Always look for active features of anaphylaxis. You have to look actively to see anaphylaxis, especially if the patient is not responding to you. After a dose of piperacillin and tazobactam, the nurse says that the patient is not responding in the next 20 to 30 minutes. Patient is dyspneic, there's a lot of wheezing, and when you go to the patient, if you don't suspect anaphylaxis, you will not detect anaphylaxis because it's life-threatening. You might not see angioedema, that is swelling around the face, you will not see. But if you see breathlessness, if the blood pressure is dropped, right, if the wheezing is there, then think about anaphylaxis. Look at the rash. Again, we are dark people, Sri Lankan, we might not see the rash, but look for other signs of anaphylaxis and think about it. Patency of the upper airway is very, very important. The way that you can identify the patency of the upper airway is the emanating sounds from the breathing effort. So if you have upper airway obstruction, you will have like what we call stridor. When you have obstruction of the larynx and above, you can have stridor, right? And you can have some very harsh sounds when the trachea is obstructed. So sounds of breathing is important in this patient to see whether this airway is patent or not. If a person can have the ability to say that "Mahathaya mata husma ganna baya" in one word, probably that person is better off than a person who says Mahatya and then stops, right? So ability to complete a sentence, you can just usually use "Mokohomada then," how are you? Ability to speak a sentences will give you an idea how severe the sentences is. You don't need a peak expiratory flow rate. You don't need a spirometry. You don't even need to listen to your lungs. Especially clinically, you can think about how difficult this patient is having to breathe, right? Cardiovascular status again is very important because breathlessness can be due to many causes, right? Now I have about 2 months back, I had a lady 6 weeks after postpartum coming to me basically with breathlessness, and she was sitting and she was looking ill, right? And the blood pressure was okay, 100 by 70, tachycardia was about 110, saturation was okay, but we were wearing, she was wearing a mask when she came to the practice, and I asked her to remove the mask, and she was pale like nothing. Hemoglobin was 4, right? So remember, breathlessness can happen because of other things as well, not only respiratory. Severe anemia, acute anemia, cardiovascular diseases are other causes other than the acidosis that we have to think about. So keep an eye on that. So when you approach a patient with breathlessness, you have to approach the patient very quickly. Look at the patient, conscious level, respiratory rate, whether the patient is cyanosed. Look for active evidence of anaphylaxis. Look for sounds of breathing, whether this patient can speak in one verse. And then look at the cardiovascular status, because respiratory pathologies can affect the cardiovascular system. At the same time, cardiovascular system pathologies can affect the respiratory system, causing dyspnea as well. Right. One of the most important things after this initial assessment of this patient is to check for the saturation. Right. So I can't, tell you enough. Even if you go to as an OPD doctor or a doctor at a peripheral unit, or when you're doing even private practice, if a patient complains of breathlessness, please check the saturation. Other than you are checking the respiratory rate, agreed, you are checking the depth of respiration, you are checking the blood pressure, you are taking the pulse rate, you are looking at whether the patient is febrile or not. Those are very important as well. But after that initial assessment, check for the pulse rate or saturation of the body. That is very important because some of these patients who have hypoxemia might not, be very distressed, right? Unless you check for the saturation. What you measure by the pulse oximeter in saturation is that the percentage of hemoglobin that is saturated with oxygen, right? Even though sometimes when the blood pressure is low, and in conditions where you can have discolored nails, in females it's very common when you use the nail coloring, and in certain conditions where the peripheral blood flow is not there, like scleroderma, you might not get the pulse, what you call this pulse wave in the saturation probe as you like. But even then, in a normal person who comes to you, always check for the pulse rate as well as the saturation, because it's very important. And as medical students, I would rather like you to have a pulse oximeter with you. It's about 2,500 to 3,000 rupees, right? And you can keep it in your pocket. After examination, complimentary, you can check for the saturation. So later, you will understand the positive and the negative features of pulse oximeter, right? Right. So after this initial assessment, you assess the consciousness, the respiratory rate, and then you assess the blood pressure, pulse rate, look for anaphylaxis, febrile or not, and then check for the saturation as well. And then after that, the most important thing is to do about arterial blood gas in a patient with dyspnea, especially with a patient with severe dyspnea, because the arterial blood gas will give you the exact abnormalities in your blood. Ideally, you have to think about the tissue level hypoxemia and hypercarbia, but arterial blood gas will be giving you an exact idea about what is happening in the blood. So in an arterial blood gas, I think most of you have seen an arterial blood gas. You will have the partial pressure of oxygen, right? It should be about 100, right? Or more than 100. So you will have the partial pressure of carbon dioxide, right? In a normal person, probably 35 to 40, right? So you can have the pH 7.35 to 7.45. So those are three most important things that you can look for. So if you are hypoxemic, the partial pressure of oxygen will be lower than that, right? And if you're having hypercarbia, you can have a high carbon dioxide value, maybe 60, 65, 70 value, right? So sometimes even a normal carbon dioxide level is very important, especially in a patient with asthma, where in a patient with asthma, you will have increasing of breath share, ventilation, increased respiratory rate. Usually when you have increased respiratory rate, the carbon dioxide, you expect it to be washed out in asthma, but when you see that the carbon dioxide levels are rising up to 35, 40, that means that the patient is getting exhausted. So even in a setting like acute severe asthma, a normal carbon dioxide should worry you. So that is why it is important according to the clinical context, right? In a chronic COPD patient, a carbon dioxide of even 70, we might not worry much. If the pH is normal and the patient is not acidotic and it is compensated by the bicarbonate of by the kidney system, right? So look at the high oxygen level in acute shortness of breath, look at the carbon dioxide level, and then the important thing is look at the pH, right? pH is very, very important. It should be in the normal range. And another important thing that I will look in arterial blood gas is the lactate level, right? The lactate level will tell you whether there is a tissue hypoperfusion or hypoxemia. Right? Sometimes you might have a normal carbon dioxide or oxygen level, but then, or slightly reduced carbon dioxide level, but then your lactate level will rise. So if that is so, that indicates probably tissue hypoxemia and hypoperfusion, or sometimes in certain poisonings as well, you can get an increased lactate level without those happening, right? So it is very important to look at the lactate. I will not confuse you further. Look at the oxygen levels, look at the carbon dioxide level, look at the pH, right? And look at the lactate level. So at the basic level, I think that will be more than enough, right? FiO2 ratios, the bicarbonates, and everything you can later learn slowly. But at the basic level, look at those four. And when we are informing the senior house officer or your consultant, think about those four aspects, right? So if you have reduced oxygen, partial pressure of oxygen, reduced carbon dioxide, 20, right? Then most likely you are having what we call a type 1 respiratory failure, because the low oxygen would have stimulated the peripheral chemoreceptors, increases the ventilatory drive, and then that would have washed out the carbon dioxide in yourself. So for example, COVID pneumonia, any pneumonia, pulmonary embolism will cause that type of a picture. Reduced oxygenation level with reduced carbon dioxide level. And if you look at the pH, it might be alkalotic. The pH will be more than 7.45, right? Right. And if you're thinking about a ventilatory failure, what we call a type 2 respiratory failure, the commonest cause is COPD, but it can happen in conditions like Guillain-Barré syndrome and certain poisons like organophosphate poisons. There you will have increasing of carbon dioxide level than the more than level. You will have a 60 or a 70, right? With that, if it is acute, you will have a difference in the pH. The pH will be dropping, right? It will be around less than 7.35. And sometimes the oxygenation will also slowly drop. So if you have a rising carbon dioxide, elevated carbon dioxide, reduced pH, and then you might have normal or reduced oxygen, then you are dealing with a type 2 respiratory failure. That indicates that you have a ventilatory failure in this patient, right? So together with that, with the lactate, probably you can come into certain conclusions. For example, if the patient is having a high lactate and type 1 respiratory failure, I would think about whether it's a severe pneumonia, right? Okay. I hope that until now, this is clear. But after everything, after looking at the conscious level, respiratory rate, blood pressure, anaphylactic features, right? Talking with the patient, there are two things that I would like you to think about. One is whether the patient is febrile or not, right? Sometimes we might miss certain things. Sometimes if you don't touch we will not feel whether the patient is febrile. So in a patient with short of breath with fever, our differential diagnosis differ from a patient who doesn't have shortness of breath and fever. I agree that certain people will not have fever even when they have a pneumonia or a chest infection, but this will help you to see whether there is an infection or at the basic bedside, right? And the other important thing is, please learn how to check for the trachea. That is a very important sign, especially in a patient with shortness of breath. Okay, so if you look at a person and if you can follow the trachea from your throat up to the sternal notch in a single line, and then look at the laterally, if you can push your finger in, and then you can see whether this trachea is deviated or not. Because a deviated trachea will tell you basically whether the mediastinum is pushed to one side or pulled to one side. So if you have a large pneumothorax in one part of your chest, you will have a pushing of the mediastinum, pushing the trachea as well together with it, right? But if you have a large pleural effusion also, yes, you will have a pushing of the trachea to the other side, and that might be the reason for the shortness of breath. And at the same time, a child or an adult who has aspirated and as a result collapsed the complete lung, left side of the lung, then again you will have a pulling of the lung to that side. So there the trachea will be deviated to the same side of what you hear that is abnormal, right? So identifying the trachea and identifying the position of the trachea will tell you a lot of things, especially if the patient whom we are suspecting a pneumothorax and a large pleural effusion has tracheal deviation, okay, that indicates that this tracheal deviation can cause reduced venous return to the heart, and the patient can, go into hypotension, hypoxemia very quickly. Hence, you have to do something very quickly. That might be a sign of what we call tension pneumothorax, where the diaphragm will be also pushed down in these patients because of the pressure of air here. Actually, if it is due to pleural effusion, I would like to call it tension pleural effusion, because we have seen enough pleural effusions, large pleural effusions, causing the same effect, pushing the mediastinum to the other side, reducing the venous return. Hence, the patient will go into shock. The diaphragm is not working properly because the diaphragm, the curvature of the diaphragm is not like this in this patient. It's going down like this, right? And hence, the diaphragm is not working, and the patient might go into the difficulties very quickly. So as a house officer, as an early house officer, as a doctor, we have to think about these symptoms as early as possible, right? So learn to check for the trachea. If you can't identify anything in the respiratory system, I don't mind, learn to check for the trachea correctly, right? So these, to illustrate some signs, I think you can identify what I'm talking about, the central cyanosis. Now remember, now in Sri Lanka, we are dark people. Sometimes we will not see the cyanosis as it should be, right? But you can see the tinge of cyanosis in the nose as well as in the lips, right? And we have edema of the lower limbs as well. So when a patient comes with lower limb edema with shortness of breath, our diagnosis might, wonder whether this patient has either a cardiac disease where they have an increasing amount of venous return, venous pressure causing significant amount of bilateral ankle edema, like congestive cardiac failure, or else the patient's having a primary pulmonary pathology like COPD, which has affected the right side of the heart, causing copulmonale, that is causing bilateral ankle edema. Now, identifying edema in a patient with COPD is also important because these patients tend to develop carbon dioxide retention when you give high flow oxygen than in patients who don't have that aspect. So, edema is a very important thing that we have to identify in our breathless patient. And I will also look at the jugular venous pressure. These are very, very simple physical signs. I can tell you about 50 physical signs in this lecture, but what I want to do is to keep it very, very simple, because when the patient is in distress, you will not get a chance to look at each and everything. So important physical signs, what I would like to stress is that whether the patient is febrile or not, look at the trachea, see whether the patient is tyanosed or not, and see whether the ankle edema is there. Have a look at the jugular venous pressure, right? So if you have a pulsatile jugular venous pressure going up and down, right? So probably that might indicate, most likely that will indicate increasing of right heart pressure, right? That can happen in congestive cardiac failures, copulmonale, right? In pulmonary embolism, where the pulmonary artery is, blocked, you can have acute conditions. Are these conditions that you have to think of. Or else you can think about a pericardial effusion as well, even though the pulses, the waves might be different, but you can think about the pericardial effusion as well, especially if you hear a muffled breath, a heart sound in the mediastinum. But if you see a jugular venous pressure which is not pulsatile, right, up to the earlobe. Sometimes even you have a large, elevated jugular venous pressure, you can have the earlobe, pulsating, right? Like in this gentleman, it's almost here now, right? So, but even up to the earlobe, you can't see a pulsatile, but it is distended, right? Then we have to think about a very important condition called superior vena cava obstruction. Because if you don't see a pulse, then that means that the venous flow is obstructed. That might indicate a malignancy or a thrombosis in the vena cava, which might be obstructing the venous flow. And if you look closely, you might see dilated vessels or dilated veins in the anterior thoracic region, which might further suggest that this patient is probably having that. Why do we have to identify? Because that is an oncological emergency and you have to do the needful to identify these patients. And probably this patient is shortness of breath because of this malignancy causing a massive pleural effusion or obstructing the complete lung and causing a large collapse. So we have to identify those clinical features very appropriately. Right. So physical exam, think about the cyanosis, look at the edema, look at the JVP, and especially I would like to stress that in a patient with shortness of breath, or when you feel the pulse, feel the palm as well, right? So when you feel the pulse, you can have two types of pulse. It might be a thready, low volume pulse. Then probably you are dealing with something like a myocardial infarction, or the patient is, something like that, right? Sympathetic overdrive is there. But if you see a bounding pulse, right, bounding pulse, even though the pulse rate is, blood pressure is low, think about sepsis. And this important other thing is think about anaphylaxis if you see a bounding pulse. Third thing, if a patient has, for example, bilateral mild ankle edema, emaciated patient, underlying COPD, think about carbon dioxide retention. You don't need an ABG to diagnose carbon dioxide retention in a COPD patient. Look at the pulse, a bounding pulse. Look at the arms, palms. It should be warm in COPD patients with carbon dioxide retention. And at the same time, do like this, right? And keep down like that. And if you see flaps, yes, then probably this patient is having carbon dioxide retention and it is affecting his central nervous system. So I told you that sometimes even 70 might not affect the patient. But in these patients, the patient might go into carbon dioxide retention very quickly, and then the patient might go into coma very quickly. So those are the clinical features that we have to think about. Cyanosis, obviously. Think about JVP. Take the pulse. Look for flaps as well. Right. Auscultation is important. But without a stethoscope at hand, even, you should be able to identify most of the problems that occurs in patients. Stethoscopes will come next, right? Before auscultation, I would like to stress the importance of percussion, right? You might not be able to, examine the respiratory system proper in these patients, but after checking for the trachea, percuss and see. So if the patient has a trachea that is deviated to your left side, right? And if your percussion note is hyperresonant on the right side and normal or dull in the left side, then you know that probably this patient is having a pneumothorax. If the trachea is shifted to your left side again and you see a stony dull or dull percussion note,
Hello.
Neranjan, I think you have muted your computer.
Hello. I think he has left. Neranjan is there.
Can you hear me now?
Neranjan, yes.
This is not muted.
Yeah. Now we can hear you.
Domindra kata kare.
Yeah, you can hear you now, Neranjan. We can hear you.
Professor Kudagamana, can you hear me?
We can hear you.
Hello.
We can hear you, Neranjan, now. Can hear.
Metin na gannako.
We can hear you now, Neranjan.
Make a mute. Hello.
Yes, Neranjan,
Yes. Now we
Hello,
can hear you.
Can you hear me?
Yes, we can hear you.
Okay, so you can now hear me, isn't it? Okay, right. Okay. Nilanti පොඩ්ඩක් confirm කරගන්න දුමින්දර කතා.
We can hear you.
Yeah.
Right. Yes, can hear. Okay, so there's a message saying that yes, can hear. I'm sorry, I know I was not muted actually. Hopefully you can. Can I know from how long that you couldn't hear me, please? Can someone type 5 minutes, 10 minutes, more than that?
It was about just about 2-3 minutes, Neranjan.
Okay, from the dullness and the trachea shifted about 3 minutes. Okay, thank you very much for your feedback as well. So that means you are listening as well. Right, okay. So anyway, what I was talking about was basically about the trachea. So if the trachea is deviated to the left side, and if you hear the dullness in the left side and the abnormal side in the left side, that means the trachea is pulled to your left side. That indicates probably a collapse of a lung, okay? That the pathology is in the same side. But if you have the trachea deviated to the right, again the left side, but you hear reduced breath sounds in the right side, okay, and a percussion is hyperresonance or dull or stony dull, then probably something is pushing the trachea to the other side, but remember, medicine is not that simple, but at least it will be helpful to have a guide like that. Okay, so to make matters a little bit easier, I was taking this time to basically to explain to you the importance of analyzing shortness of breath. So when we go back and summarize of what we talked about up to now, one thing we spoke that breathlessness is a very, very discomfortable feeling, uncomfortable feeling, where the patients will be very, very distressed, and it will depend on the social and the psychological factors of these patients. Breathlessness will indicate a condition that might be simple, such as anxiety, but life-threatening, such as pulmonary embolism. Hence, identifying the correct cause and treating appropriately is very, very important. Third, there are many, many pathophysiological phenomena that is underlying the shortness of breath, where the airway narrowing, increased workload, increased interstitial pressures, hypoxemia, hypercarbia, and acidosis are the mainstay underlying causes, and the treatment modalities will differ. Hence, important to identify the underlying cause properly in these patients. What the patients will be, we will be helped by certain features to identify the severity of the shortness of breath and probably the underlying cause, mainly when we approach the patient to look at the patient's consciousness, the respiratory rates, the cardiovascular system, the blood pressure and the pulse rate, and whether the patient is having fever or not. Having a look at whether these patients have features of anaphylaxis, right? And then examination, the features such as cyanosis, the wide pulse rate, the flapping tremors, the elevated jugular venous pressure, as well as the trachea, as well as the lung signs that we have, right? So these are the baseline things that I would like to discuss with you about. But in an acute setup, I would like to discuss about 5 ways that these patients can present to you, so that it will be easier for you to think about the underlying cause. You know, in any medical exam or in a medical situation, in a medical situation, we think about the underlying causes, the differential diagnosis, the possible causes, right? And in your mind, always we have to have certain probabilities coming up and certain probabilities going down in your list. So we'll have a good differential diagnosis list. But that doesn't mean that you have to have a differential diagnosis about 20. No, you should at least have in your level about 3 or 4, maximum 5 differential diagnoses for a presentation. Sometimes it might need only 2. Sometimes you will diagnose as early as possible. But to help you that, because you have sometimes your first differential diagnosis might not be the correct answer, it might be the third one, but it was in your thoughts, so you will not miss that, or else you will miss the possible diagnosis. That's the importance of having a good differential diagnosis list. But this differential diagnosis should have a possible underlying scientific basis, okay? Or else, you know, you will just be telling 5 causes, right? So like 5 causes of diarrhea, right? You will just remember 5 causes of diarrhea and tell. But and always in our level, especially because I heard that you are doing clinicals at the moment, 3rd year and above, always we have to relate to our patients. So when your consultant asks you what are the causes of diarrhea in this patient, you know, you have to tell what is relevant for that patient, not the whole 5 causes. So my important stressing point here is that when you approach the patient with shortness of breath also, we have to have a possibilities of these patients, at least 1 or 2, 3 possibilities in this patient that might be causing this shortness of breath. So what I suggest is that you can have your own methods, but suggest is that to, you know, have a certain very good underlying firm way of identifying these patients. One of the most important way of identifying is a noisy breather clinical presentation. These patients will come to you with right, like that, right? So when you see an inspiratory sound, right, without a significant expiratory sound in a person, in most of the instances, that is what we call stridor. Stridor, to have stridor, that means you have large airway obstruction. At least 90% of your airway should be obstructed to have stridor. Sometimes it's more than that, right? Right? So that obstruction can be a transient obstruction due to a vocal cord dysfunction, where the vocal cord will go into spasm, especially very common in young females, right? Or else it can be something like a aspiration, which is blocking the upper airway. Very common in small children as well as in elderly adults, where dentures are the most common cause, right? Or simply in a ward, post-surgical person will probably have aspirated what he have ate just now, right? Food aspiration is very common, because sometimes I have tried to correct this many times. Surgical patients with abdominal surgeries are kept like lying down and you know, without any propping up, and they will definitely be aspirated on their own fluids, gastric fluids, rather than food, right? So aspiration, noisy breathing is very important in children. I think Professor Kudam will agree with me. Epiglottitis and conditions in the larynx are very, very important. Right? They will have a changed voice. They might not be able to swallow properly, but they will have a noisy breathing. These patients are urgently need to be addressed to. Their concerns need to be addressed to very, very quickly than late. Right? So identifying noisy breathing and identifying it as stridor is very important. Inspiratory sound. Right? Expiratory might not be sound where you don't hear, you might not hear a sound. The second group is a wheezer. Right? Sometimes you can hear wheezing in your own ears. You don't need a stethoscope to hear that. Okay? So there you will hear this polyphonic musical sound, which is different from the stridor, where at first you will hear the expiratory sounds rather than the inspiratory sounds. And the expiration will be prolonged. Right? Something like that. So there will be expiration will be prolonged, and you will hear this polyphonic sound rather than the inspiratory sound might be normal in this patient. Later, you might hear inspiratory and expiratory sounds. Even in UK, when I was a registrar there, sometimes stridor was misunderstood as wheezing in certain groups of people and was referred to us, to respiratory people, to address. And we had to look at the diagnose and refer this patient to emergency to the ENT group, right? So a noisy breather, a person who is coming with breathing noises, right? In acute setup, that will be the stridor. In the chronic setup, you will get a person who says that he snores, ratagorono, right? And most likely the wife will complain, and was actually a cause of divorce as well, it seems, right? Unfortunately, it's not the thing now, right? Okay, so because actually husbands know than females, men know than females. All right. So basically, when you go to sleep after some time, when you are in the REM sleep, if you start to breathe noisily, that indicates snoring. That also indicates upper airway obstruction because of the pharyngeal muscles are collapsed and the tongue goes down, and you can block the airway, and sometimes you go into apnea where you don't breathe at all. Okay, so when chronically, if that happens, the patient will be going into hypoxemic episode with carbon dioxide retention, and later they can go into pulmonary hypertension, right? If not identified properly and corrected. And in the long term, they can have sleep deprivation. They are very prone to accidents. And if you look at accidents happening at night, sometimes they say mutton in the gear. That is one of the major causes of obstructive sleep apnea, causing sleepiness and causing accidents, not for himself, but the other society as well. For the person, it increases the risk of stroke, ischemic heart disease, diabetes, and in males, it's a cause of importance as well, sexual dysfunction as well. So snoring is a very important aspect that you have to take for, especially if the patient complains to you. It's not in the acute setup, but in the acute setup, stridor is very important. Upper airway obstruction. The wheezer, that means the airways are narrowed, the small airways are narrowed. Small airways can be narrowed acutely because of pneumonia, rapid inhalation of toxic substances, but the most commonest causes are COPD, obstructive airway disease, asthma, and sometimes even bronchiectasis. So wheezer, the main pathology is in small airways of the lung. Hence, the treatment should aim as relieving of the small airway obstruction. Okay. Then the third thing is the unilateral silent chest. When you listen to the lung, you will hear reduced air entry or reduced breath sound in a side of the lung. That it should be alarmed. You should be alarmed. So when you have reduced breath sounds or absent breath sounds in a part of the lung, side of the chest, you are dealing with probably a large pneumothorax. You are dealing with probably a large pleural effusion. Rarely, you might be dealing with a large collapse, right? If you see what you call this pneumonectomy scar, yeah, you might be dealing with a pneumonectomy as well. But don't think about it. Think about those three things: pneumothorax, large pleural effusion, or a collapse in a patient. The trachea will help you to differentiate. The percussion note will be helpful to differentiate. Okay. Right, silent chest. The second is febrile and septic. Now, in these instances, in the current status, it's very important to identify these patients very properly, because patients who are septic and febrile can present to you and they might not complain at all. Hence, any patient who comes with fever, shortness of breath, assume that the possible diagnosis is pneumonia, and then you have to investigate it further. Probably sometimes the primary site might be a UTI, and you can have secondary acute respiratory distress syndrome, but it comes later. But think about pneumonia in these patients, because you have to start antibiotics as early as possible. Resuscitation in this patient is completely different from a patient with unilateral silent chest or a wheezer or a noisy breather, right? So that is why what you do will depend on the underlying cause, right? Normal chest is another one where, after examining the patient properly, in a patient with shortness of breath, the most, in my life, having a normal chest is a problem, because then we have to think about other sinister diagnoses, right? In a patient with deep acidotic breathing, it might be acidosis that is causing the normal, shortness of breath. Or it can be something like a pulmonary embolism, where you auscultate, but you can't see any abnormalities, hear any abnormalities, nothing is there, but you can have a pulmonary embolism that is causing the problem. Or sometimes it can be the heart that is causing the shortness of breath, right? So it is very important to think about these aspects, because a noisy breather, we have to rapidly, if it is an acute problem, we have to rapidly relieve the upper airway obstruction as early as possible. If you can't relieve the upper airway obstruction, you have to at least put a tracheostomy, right? If in a visa, the main pathophysiological abnormality is a small airway where it is sensitive to the beta agonist as well as antimuscarinic agonist, salbutamol and ipratropium. So we have to dilate these vessels, dilate these airways as early as possible, right? Or else the patient will go into exhaustion and type 2 respiratory failure, right? And you have to, especially in COPD, you have to control the oxygen. In a unilateral chest pain, silent chest, there is no use nebulizing the patient, right? You have to diagnose a pleural effusion or a pneumothorax. If it is tension pneumothorax, put an IC tube to relieve the problem. Later we can think about the diagnosis. There's no way about. If it is a collapse of the lung, you have to relieve the collapse. You might have to do an urgent bronchoscopy and remove the particle out. Or an ENT referral is needed if it is a tracheal obstruction. Febrile aseptic, no, even the patient is shortness of breath. If you don't hear rhonchi, there's no use nebulizing these patients. You might increase the risk of spreading the disease to another person. So the important thing is identifying whether the patient is septic, starting appropriate antibiotic and starting appropriate resuscitation, especially if the patient is having a hypotension as well. In a normal chest, with the patient having shortness of breath, think about whether this patient is pulmonary hypertension. No use nebulizing the patient, right? No use giving an antibiotic for this patient, right, if you don't think that it is pneumonia or sepsis. So think about this aspect. So that is why it's very important to identify and think about the underlying causes before you do something appropriately. But remember, sometimes you can have conditions happening together. You can have a COPD patient who is wheezing and septic because of an infection and a pneumonia. Yes, you have to do both then, right? You can have a anaphylactic patient with wheezing and angioedema. The reason for the shortness of air and giving the antibiotic was for the pneumonia, and he's septic as well. Yes, we have to treat both the things together. There's no problem about it, right? You can have a COPD patient who comes with acute exacerbation like a picture, and you have a unilateral silent chest. He might have a pneumothorax on top of that, right? So you need to think about that. A visa, that is why you get 5 years of training, 5 years of in a university, in a medical faculty, and that is why the best of the best are selected to study medicine, right? And taught for 5 years in a medical faculty by brilliant teachers, right? Whom we were fortunate to have in our time, and whom you are fortunate to have now, who, without their input and without their interest in teaching you, even these programs would have not happened, and you are very fortunate to have these teachers with you. Right. A noisy breather, there is an upper airway obstruction, airway obstruction. It can be the tongue falling back, the pharyngeal muscles collapsing. You can have epiglottitis, edema, laryngeal edema, tracheal obstruction coming into the picture, right? So depending on the cause, you have to think about the things that you have to do, as I told you previously. A visa, asthma is one of the causes where, as I told you previously, there is a narrowing of the airway. So I think in these next 2 or 3 slides, I will help you to differentiate asthma and COPD, because diagnosis is different. And if you look at the book, unfortunately, if a clinic book is looked at, you will see that it is most of the time mentioned as asthma, but to see that the patient is having COPD. And the diagnosis and treatment modalities are completely different in certain groups of people. So in asthma, the main problem is there is an inflammation in the airway, a transient inflammation in the airway. In most of the instances, it is a eosinophilic type of inflammation mediated by, as well as in IgE mediated inflammation, right? We call it Th2 type of reaction, but there are other types of asthma that we have to know, but it's not very important, where you can have inflammation and the airways are very, very hyperactive, hyperreactive, and because of that, they can go into chronic spasm. Sometimes the trigger can be exposure to a substance that triggers the reaction, like in certain allergic components, or it can be something like a trigger because of an infection. What I have seen is infection are the most common cause of asthma exacerbations in Sri Lanka, maybe viral infections. But there what happens is these airways are rapidly narrowed, and these narrowed airways secretes mucus as well, and there will be mucus impaction as well in these airways. Hence, the patient's airway are narrowed. As I told you previously, the resistance to airflow will increase. Hence, the work of breathing will be increased. And when these airways are narrowed further, the patient will start to wheeze because the airs will be flowing in a narrowed airway. Later, when the airways are critically narrowed, you might even hear a bilateral silent chest in asthma. That is a very, very important aspect. Silent chest in asthma, patient is breathing. Next, probably it's an impending arrest, respiratory arrest, right? So airway narrowing is the one that we have to treat in asthma, right? So airway narrowing should be treated ideally with back-to-back nebulization with beta agonist and antimuscarinic agonist, atropium as well as salbutamol. There is a place to magnesium as well, right? I will not tell you the doses because you will not remember them. You have to look at the literature to find the exact doses, the guidelines to look at the doses, because now this is not the time to teach about doses, but basically the underlying mechanism of management is dilating these airways as much as possible, as early as possible, where the most important thing is beta agonist. You can give it nebulization and even intravenously as well, salbutamol, under critical cardiac monitoring, because they can trigger arrhythmias. Nebulized ipratropium bromide, right? Short-acting antimuscarinic agent, which will act in the airway. So you are dilating the the bronchi in two ways, by beta agonist as well as antimuscarinic agonist, because reducing the vagal tone will also help in these patients. And then magnesium sulfate, it fights with calcium for binding, and it has a vasodilatory effect. Sometimes if it is severe, you can give IV magnesium sulfate, and it has proven. Theophylline, aminophylline, the benefit is not disputed, and it has a higher risk of developing into arrhythmia, especially when we are nebulizing these patients. There will be hypokalemia in these patients, and the hypokalemia and increasing level of aminophylines might trigger cardiac dysrhythmias, but sometimes I use it as well if the patient is not responding, right? And how can you measure the severity? I would do an arterial blood gas in a patient with asthma, and if the PCO2, carbon dioxide, is about 20, I will be happy. But if it is coming to 30, 35, this is almost near fatal and severe asthma. So we have to manage the patient as such. Clinically, how can you measure whether the patient is having severity? There are a lot of methods that are given in books, peak expiratory flow rate, respiratory rate, and things like that. But I go by whether the patient can continue a sentence. If the patient cannot continue a sentence at one go, you have to be very careful about the patient, and you have to monitor the patient closely. But always in your exams, you should know exactly what to look for, and you have to write them in the MCQs as well. Okay. If a patient doesn't respond in asthma, you have nebulized, but the patient is still not responding, think about two important things. One thing is, when you nebulize these patients with ipratropium, and when the patient is hyperventilating in asthma, what will happen is the airways will be drier, will be dry. Hence, the mucus that is already there can be impacted, and you can have a collapse of a lung. Okay, hence a high oxygenation might not happen properly. So these patients might deteriorate rather than improving. So impaction of forming of mucus plug is an important thing, especially in children and adolescents if you are thinking about that. Second thing is probably this patient had developing your pneumothorax, right? So listen to the lung again to see whether this patient is improving or not, right? So those are the things that we have to think about when we are treating asthma exacerbation. So the pathophysiology, small airway narrowing, dilate it as early as possible, and then so dilate salbutamol, ipratropium, and sometimes magnesium sulfate. Under professional guidance, we might think about aminophylline as well, right? But think about severity, look for the ABG, look for the carbon dioxide levels, clinically ask the patient questions, conscious level, the ability to talk, and think about whether this patient, if he's not responding, whether he had developed a pneumothorax, which should be rapidly treated, or whether there's a mucus infection. Then you can think about giving hydrocortisone, think about IV antibiotics, etc. like that. Okay, right. So these are the ways of measuring the severity, but that's up to you to remember, and I'm not worried about it that much. Right. 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 COPD is rather different from asthma. Right. COPD is different from asthma, where you can have a hyperexpanded lung, where the parenchyma of the lung is also impaired. So there are two pathophysiological phenomena in the COPD lung than in asthma. Where in asthma you have an inflamed airway which is rapidly narrowed due to a trigger, which can be completely reversed if appropriately treated in these patients. But in COPD, what happens is there is an inflamed airway, small airway, but other than that, there is a emphysematous part, that is a destruction of the parenchyma of the lung as well. And you can see in this X-ray beautifully, the diaphragms are pushed down, right? Hence, the breathing effort of this patient is not properly conducted to the lung. Right? And in these patients, you would have probably seen in the previous slide, are emaciated. Their muscle mass is less. Hence, the breathing effort will be further reduced. So what happens when these patients go into acute exacerbation? Right? What happens is that these patients, when they go into acute exacerbation, the airways again will be narrowed. Right? When you have a narrowed airway in this lung, and at the same time, this patient will have a ventilatory failure as well. Unlike in asthma, where normal ventilation is there, good ventilation is there, these patients have a ventilation impairment because diaphragm is not functioning, the lungs are hyperexpanded, respiratory muscles are already weak, and these airways, which are narrowed, are easily collapsible because the parenchyma around the airways, the elastic area around the airways, is collapsed. So this will be not supporting the opening of the airways. So there will be closing of the airways. Okay. So when this happens, especially in a COPD patient going into exacerbation, what will happen? The breathing in will be impaired because the muscles are not very properly, functioning, and the breathing out will also be impaired because when you breathe out, the airways will be collapsed early. Right? When you have the airways collapsing, because this patient has to push out air actively. Right? So when you push out air actively, what happens? You're creating a positive pressure, and then these airways are narrowed. And because of that, the air will be trapped in the alveoli, which is called air trapping. Hence, again, air will be trapped. So ventilation will be impaired. Because of that, these patients will have increased carbon dioxide in their blood. Okay, hope that you can understand. So, but these patients, carbon dioxide of 70 to 80 will be tolerated than in a patient with asthma, because they have probably been exposed to carbon dioxide for a long time, right? But one thing that we have to remember is that these patients with COPD exacerbation have a ventilatory defect. True, they tend to retain carbon dioxide more, and hence the pH will also be low, so they go into type 2 respiratory failure very early. But the important thing is they can go into hypoxemia as well. They can have a reduced oxygen level of the lung body as well, right? Now, what happens if we try to correct this oxygen rapidly? Now, we know in any hypoxic patient, we have to give oxygen. Our target in a hypoxic patient is usually around 94 to 98% of saturation, right? But in these patients who are having COPD, right? Now, usually our respiratory drive is driven by carbon dioxide. So whenever when your carbon dioxide gets higher and higher and higher, pH is getting lower, stimulate the respiratory system, and you will start to breathe. Just try to breath hold for 1.5 minutes, and you will definitely be overridden by the normal respiratory system, right? But in these patients, because of the chronically elevated carbon dioxide levels in our bodies, their chemoreceptors, the central chemoreceptor, is not sensitive to the high carbon dioxide level. That means it doesn't, it is not stimulated. The respiratory center is not stimulated by high carbon dioxide level, but it is stimulated by the hypoxemic drive. the low oxygen level of a person, right? So they maintain their ventilation or breathing because of the low oxygenation in the body. So that doesn't mean that you have to allow oxygen of 70%. No, right? We have to be careful, especially in these patients, to maintain their oxygen level not more than 92%. That is 88 to 92%. So they should be given what we call controlled oxygen, not high flow oxygen, right? That is, the priority should be to bring their oxygen to 98, 88 to 92, not 94 to 98. COPD patients, bronchiectatic patients. But in asthma, you have to give 94 to 98 because these patients didn't have chronically elevated carbon dioxide and their respiratory center is very sensitive to carbon dioxide, and you have to correct the oxygenation, hypoxia, right? But in these patients with carbon dioxide retention or COPD, we give controlled oxygen, 88 to 92%. That is our target, but not lower than that. Low oxygen than 88 will be harmful for that patient, right? And at the same time, that's where we give controlled oxygen, right? So that is one important aspect that we have to remember in patients with COPD. Okay, right. The second aspect in COPD is I told you that these patients will have narrowing of the airways. So in COPD, probably we learned that it is irreversible airway damage and it is not opening up, but there is a certain group of airways that are opening. Hence, bronchodilation is very important in this group as well. So we have to go for, okay, there is a hand elevated. Is there a question? M14067. Is there a question? Please, if there is a question, can you type in? Right. Okay. So this, I hope that you can hear properly. If not heard, can you tell me? Okay. So you can hear. Right. Good. So in these patients, right, I have a message. We'll see. Can hear. Okay, right. So hopefully you can hear. So carbon dioxide will gradually accumulate unless we bronchodilate. So we bronchodilate with salbutamol and ipratropium nebulization first, and then sometimes we give, the main important thing is to dilate the airways, similar to asthma in that aspect. But when we manage, we have to think about oxygen giving very in a controlled way. And the important thing is these patients, because these airways can be collapsed and narrowed and the ventilation is impaired, sometimes we need ventilatory support, right? Ventilation is you are helping to the patient to breathe in and out, mainly breathe in. You are supporting the breathing in, right? So you can give ventilation in several ways, right? Yeah, there's a question saying that controlled oxygen to COPD. I explained it, right? Okay. So basically, we give in non-invasive ventilation. Now, ventilation, you have seen patients who have probably been into the ICU in Peradeniya, and they are intubated and pushed in air that is ventilated in the ICU. You have to paralyze the patient, and it's a long process. Patient can get pneumonia, it's complicated, right? But here, what we call it is non-invasive ventilation, and you can beautifully see we can create a pressure around their nose and the mouth without putting tubes in, right? In certain groups of people in which this method is indicated. Who are the people that will be benefited here? The important group of people with COPD is that they should have a pH less than 7.35 and the carbon dioxide level should be high. So, or else they should have type 2 respiratory failure with acidosis. So these patients will be, if not improved by the normal medical treatment that we usually give, bronchodilators, sometimes steroids, and sometimes other treatment, if the patient doesn't respond, then we have to think about non-invasive ventilation. Now, earlier when I was a house officer in 2001-2 in Kandy, and even in registrar to one of my greatest teachers whom I really respect, Dr. Harith Vimalratna. Sir, and when we were house officers and registrars, right, we were actually, we were helpless when a COPD patient came to us. Right? They were just grasping for breath. Only thing we can give was oxygen, nebulization. We gave aminophylline, sometimes even magnesium sulfate. We supported with everything that we can have in this patient, but sometimes we couldn't save the patients, and the patients succumbed to their illness. But when I did the senior registrarship with my mentor, Dr. Dishant Madagadara in Kandy, we slowly had the ability to start non-invasive ventilation to a certain extent, and it was available. And now it's widely available throughout the country. So in COPD patients with type 2 respiratory failure, now we have a beautiful treatment modality called non-invasive ventilation, and you will be certainly exposed, and Duminder will certainly teach you about it during your ward rounds and in your respiratory appointments about the modalities. Probably you would have seen this method during your respiratory and medical short appointments. So it's a very important aspect that you have to think about, and you should know about this, and you should be able to put an NIV. It's not rocket science, right? For us old people, it will be a little bit difficult because of these small technical things. Now, even to get the computer up, I needed my son's help, but for you, I think it will be very easy for you to put up. Right? But understand the basic principles. Non-invasive ventilation will help ventilation by two things: supporting the respiratory muscles to breathe, the diaphragm and the muscles, so pushing air. And at the same time, even in expiration, it will keep a pressure we call EPAP, or expiratory positive air pressure, or positive expiratory airway pressure, PEEP, right? Positive end inspiratory pressure. So it will be keeping it, and because we keep a pressure even at expiration, because the airways will not be collapsed. Hence, the air will be made patent, so that the air will be able to completely come out from the lung. Right? So that is why we are giving NIV, and it's a beautiful method. Most of the patients we can save. Right? Right? So sometimes you can get these type of X-rays. So actually, Tilaksa wanted us to do a class on X-rays. So we'll probably, Duminder and I will be planning a beautiful class maybe in the next 2 or 3 months. But you can see now in this patient with a shortness of breath who came to us, you can have what we call bulle, right? In a COPD patient, you can have, this is not one of our patients, right? You can have what we call bulle. So sometimes when in a COPD patient, you might have unilateral reduced breath sounds with a central trachea, and the X-ray might mimic a pneumothorax. So if you are not clear about that, seek senior opinion. One thing that you might help to identify is that compare previous chest X-rays. Obviously, the patient will have a lot of X-rays when they come. Compare previous X-rays to see whether this was there from the previous, right? Second thing, right? The important thing is usually in a bulle it will be convex, right? This thing will convex, but in a pneumothorax it will be something like that, right? So you will see the lung margin properly. So those two can be helped. But we had an incident in even when I was in UK. One of the medical registrars has put IC tube into a bulle, and if you put a IC tube into a bulle, the patient will have a bronchopulmonary fistula, and that will have severe consequences to the patient. But you don't think that you might do harm for the patient, but always be careful about bulle in COPD patients, right? Okay. Unilateral silent chest, you can understand what is there. It can be filled with air, pneumothorax. It can be filled with fluid, pleural effusion. Right? It can be blood in trauma, hemothorax. Right? So here, it's a beautiful tension pneumothorax you can see. Right? The diaphragm in the right side is pushed down. That is a very important sign that you have to look for. First thing, there is hyperlucency in the lung. You can see that the mediastinum is pushed to the left side, and there is a slight collapse of the lung in the right side, left side. Right? So this is almost a tension pneumothorax. What will happen next? Why are we worried about a tension pneumothorax in this patient? You can see that the right heart is also, this positive pressure that is building up will reduce the venous return that is coming into the right side atrium. When you have reduced venous return coming into the right atrium, right, what will happen? The patient's blood pressure will crash and down. It will go down. And when you have a massive pneumothorax like this, this lung is not supporting the oxygenation process, and then the patient will go, and this lung is also compressed, the patient will go into hypoxia. So hypoxemia, hypertension, if you don't correct it, the patient will die within a very few minutes, right? So remember, trachea, dullness, hyperresonance, then you can diagnose. It's not very difficult, only to suspect. Again, a beautiful pneumothorax, right? No lung markings at all. You can't see any lung markings at all, right? Collapsed lung here, diaphragm is pushed out. Okay. Pneumothorax, you can see a beautiful lung margin. This is what I was talking to you about. That is a convex margin like this, uttala, not avatala, right? So convex margin like this. But when you have a bulle, you will have something like this, right? So it is. I think I, told it incorrectly last time. So I'm sorry. I would like to correct. This is the convex uttala, right? So you can have a pneumothorax like that. And here you can see a collapsed lung here. Okay. Again, a pneumothorax here, air filled in the air, in the lung, and you can beautifully see a cavitatory lesion in the left lung. So especially in conditions where you have cavitatory pneumonias like tuberculosis, you can have bronchopulmonary fistulas and pneumothorax happening. It's very common in Sri Lanka. And this is how they present. Okay. Now here you have a pneumothorax. You can see the blackish color compared to the left side. You can see the collapsed lung nicely, and you can see what we call a fluid level. So this is a hydropneumothorax, where you have fluid and air in the lung. That can happen actually, especially in conditions like trauma. You can have a pneumothorax, and then you can have blood filled in the air. You can have a pneumothorax. You can have an infection like that, pleural effusion with the lung, and sometimes the pneumothorax per se, because of the negative pressure, can have a little bit of fluid inside. So hydropneumothorax, and you can see a beautiful line like this. If you see this beautiful line in the lung, think about whether it's a hydropneumothorax. Even if you can't see the pneumothorax appropriately, seek for a small pneumothorax somewhere, because if you see this straight line in a chest X-ray, right, either it's an abscess, right, or insisted pleural effusion, that is a insisted pleural effusion with air, or it's a hydropneumothorax. So in a normal person, if you see that, if you have a beautiful line, even if you don't see a pneumothorax when you look at the first instance, look at the apex to see whether there is a pneumothorax, right? Then you will not miss it. Now, sometimes identify pneumothorax is very difficult. You have these arrows here. If the arrows were not there, you will find it very, very difficult. And sometimes you can confuse the scapular margin. You can see the scapular margin for a pneumothorax margin. I have seen many instances where people have confused the scapular margin for a pneumothorax. But the important things to do is, now if you look at the left lung, how do you identify a pneumothorax? You just follow these bronchovascular markings up to the end. Usually it will go up to at least about 1/3 here, right? So you can see that up to the end. But if you look at the right side, you can see that it is going up and stopping here. After that, you can't see any lung markings, right? You can't see any lung markings here. So think about that. If you are not certain whether the pneumothorax is there, translucency is there, trachea is not deviated in the early stages, you can see reduced breath sounds, take a chest X-ray in full inspiration, and then follow the markings up to the end. If you can't follow the markings up to the end, probably you are having a pneumothorax, right? Seek senior opinion. See whether the scapular margin is not causing any problem to you, right? Now, in children, especially when they are intubated and in the ICU, sometimes intubated when the lying down position, you might not see a pneumothorax like a normal person. You will not see air in the lung. But what you see is what we call the deep sulcus sign. So when you have patients with critical illness in the ICU developing pneumothorax, you might see what we call the deep sulcus sign. You can see the sulcus is very deep and unilateral, not bilateral. There is abnormality there. Okay. Right. I will not go into the measuring the size of the pneumothorax, but if you have a tension pneumothorax, you have to relieve it very, very quickly. The earlier way to relieve it is to do a rapid Thoracocentesis, second intercostal space midline, put a wide bore needle and try to relieve it. But now they suggested to put it in the safe triangle rather than going in the upper region. Try to go to the left, the safe triangle, right, fourth to fifth intercostal space. But as early as possible after stabilizing the patient, you need an intercostal tube, right? So pneumothorax is that, right? So management of pneumothorax will depend on basically whether it's unilateral or bilateral, first thing. The size of the pneumothorax, right, will be measured at the hilum level, right? And the third thing is whether the patient is having underlying lung pathology or not. When the patient is having underlying lung pathology, we call it, secondary pneumothorax. If you don't have, we call it primary pneumothorax, right? So, and third thing is the patient's clinical condition. Whether the patient is hypoxemic or not will depend on how to treat the pneumothorax. If it is tension pneumothorax, immediate thoracocentesis, IC tube, right? If it is, then the second option is putting an IC tube, intercostal tube, to the lung, right? The third aspect is to aspirate. Unfortunately, we don't have flexible pleural aspirators in Sri Lanka at the moment. We'll be getting them because what we used to do is to put a needle in and aspirate. But what happens is when the lung is expanding, the needle will damage the lung further and it might create a bronchopulmonary fistula. So I usually don't aspirate if I don't have the flexible this thing, because it might harm the lung, especially if you rupture a bulle, that will be the end of story. So aspiration I usually don't do. I either observe the patient with oxygen if the patient is stable, and if it is just a first pneumothorax and it is small. The second thing is I would decide to put an IC tube, right? If the pneumothorax is large, expanding, or the patient is not stable, immediate thoracocentesis if the patient is having deteriorating functions, right? Okay, so pleural effusion is another one, unilateral this thing, and you have to identify pleural effusions where, sorry, wanted to check, when you will have what we call the unilateral haziness of the lung. The last topic, septic and febrile patients. Now, pneumonia, unfortunately, is called the captain of men of death by Sir William Osler, who was astute clinical, he was a physician who was there, and still his words are still, as an astute clinician, as a physician, his words are still resonating among medical professionals, right? So he named pneumonia as captain of men of death because pneumonia was one of the worst causes of death, and still it is one of the major causes of death in children, adults, adolescents, unfortunately. In 1918, we lost about almost 100 million people due to influenza, pneumonia. And we are now losing millions due to COVID. And silently, each year we are losing millions due to bacterial pneumonias. So pneumonia is a huge problem. And unfortunately, we have to, we are also to blame for delaying patients being treated with pneumonia and causing deaths. In pneumonia, what basically happens is the air spaces of the lung is filled with fluid, right? And that can be seen as whitish patches in the chest X-ray. And when you listen, when you auscultate, you will hear bronchial breathing, because the reason for hear the bronchial breathing is that now this air is filled with fluid beautifully, and there is an underlying bronchus which is patent, and these sounds emanating from the bronchus is directly and beautifully conducted without the impedance of lung tissue to the ear directly. Hence, the normal breath sounds, which are the bronchial breath sounds when the air is traveled, is now heard, rather than the vesicular breath sounds, which is a result of absorption of sound waves by the lung tissue, right? So bronchial breathing will be heard here, right? So you will hear patch here, right? So you can categorize pneumonia into various regions using the Kerb's score, confusion. If its confusion is there by the AVPU rate, respiratory rate is more than 30, blood pressure and age, you can categorize into whether it is mild, moderate, severe, and it will tell us what the mortality of these patients can be, right? So the group 1, where the curve is 0, that means they don't have confusion, the respiratory is normal, blood pressure is okay, age is less, their mortality is about 1.2%. But if you have a curb stroke of 1 to 2, the mortality rate is about, that is 1 in 10 will die, right? 1 in 10 will die. If it is 3 or 4, then 1 in 3 will die, right? So that is how severe pneumonia can cause problems, right? So there you can have a beautiful chest x-ray of a female where you can have, yeah, this is the heart you can see, but out of this heart you can see a consolidated area, but you can't see the diaphragm as well. So probably this patient is having a pleural effusion as well, other than the pneumonia. And you can see another nice uh, uh, x-ray there, and here again a beautiful chest x-ray where you can see an upper lobe opacity with the S. This fissure is like an S, that means there is pressure fluid building up here and pushing down, and this is said to be a feature of Klebsiella pneumonia, right? And beautiful chest x-ray that you can
Hello, Neranjan, we have lost you. Is he still there? Oh, disconnected. Still there.
Can see the slides.
Neranjan?
Can you hear now? Can you hear now?
Yeah, we can hear now. Yes,
Still you can't hear?
we can, Neranjan.
Now we can. Okay, good. Sometimes I think this mic is getting muted without any problem. Thank you very much for reminding me as early as possible. Right. So there you have these cavitatory pneumonias. The commonest causes of cavitatory pneumonia in patients are in Sri Lanka. You have to think about tuberculosis. So if you see a patient like this, always do a sputum AFB at acid-fast bacilli. Even if it is negative, try to get a gene expert. That is a specific investigation that we analyze the genetic material to see whether there is genetic material specific to the tuberculosis in sputum, and it has a very high sensitivity than sputum AFB. So to identify one sample of sputum with acid-fast bacilli, you need about 10,000 bacteria in 1 milliliter of saliva, or not saliva, of sputum. But if you look at gene expert, you can identify if you have even 150 to 170 cells in bacteria in a 1 milliliter, and it helps us to tell us about rifampicin resistance as well, and it is more specific than getting AFB. But first line, do a acid-fast bacilli in sputum. If you have cavitatory pneumonia like that, then you can think about having a gene expert as well. That means even if you see a negative AFB in this patient, 3 negative AFBs, don't think that it can't be TB. It can be TB, so you have to investigate further. Other common causes of these cavitatory pneumonias are Staphylococcus pneumonia, which can be, the patient will be very, very ill. If a walking person has this X-ray, most likely you are dealing with something like TB. But if a patient who is very, very ill with cavitatory pneumonia, probably you are dealing with Staphylococcus aureus, sometimes MRSA. So most of these antibiotics will not cover MRSA. Hence, you need to get senior opinion about starting MRSA cover in these patients, right? This is typical tuberculosis, right? Bilateral upper zone, fibrous disease, fibrocavitatory lung disease. And even if the sputum is negative in this patient, I would highly consider tuberculosis in this patient, other than anything else, right? The normal chest, finally, but think about pulmonary embolism, a life-threatening condition that can kill patients. But in the appropriate setting, you have to think about pulmonary embolism. Any pregnant lady, any postpartum lady complaining of shortness of breath, rapidly deteriorating, think about pulmonary embolism. Any patient who has had a malignancy, who has not been able to walk during the past 1 or 2 weeks, Post-surgical patient had been in the bed for some time. Now she's developed rapidly increasing shortness of breath. Either it is aspiration or sometimes it might be pulmonary embolism. So in the appropriate setting, think about pulmonary embolism, because not even in Sri Lanka, even in USA, the post-mortem studies has revealed that we miss pulmonary embolism a lot because we don't think about the possibility of pulmonary embolism. So in a patient, they will not come with the typical sudden onset shortness of blood, pleuritic chest pain, hemoptysis, hypoxemia. No, sometimes the oxygen might be normal. They might just come with a little bit of a rapid breathing with a little bit of pleuritic pain, right? So unless you suspect these patients, you will not get these patients out. So how can you suspect? To clinically, whether it is clinically high or low, I will discuss in the next slide, because if it is clinically high, you have to investigate these patients very rapidly. CTPA is the gold standard, right? Not anything else, right? And you can do a VQ scan in the appropriate setting if the facilities are available. If the clinical risk of a pulmonary embolism is low or moderate, then you have to do a D-dimer. Right? So in a patient suspected of pulmonary embolism, we had to define the risk, pre-probability risk of having this patient having pulmonary embolism or not. So we will go into details how to determine that, right? So this is called the modified Geneva predictive risk score. I don't want any one of you to remember it, but remember these factors that, that increases your thought about pulmonary embolism, even when the clinical picture is not that suggestive. If the patient is elderly, right, more than a young person, if unless the patient is pregnant and postpartum, they have a high risk of developing pulmonary embolism. So age is a risk factor, right? Previous DVT, this patient had previous DVT. So probably this patient is having a coagulopathy, a blood coagulating abnormality, factor V laden abnormality or something like that. So there we have to think about previous DVT or pulmonary embolism, deep venous thrombosis is a high risk factor in a patient to think about the risk of pulmonary embolism. Recent surgery, mainly pelvic and lower limb surgeries, and patient has been, immobilized. Patient has not been given prophylactic thromboprophylaxis treatment. There we have to think about this. Malignant disease, whatever the malignancy, increases the risk of pulmonary embolism. Lower limb pain suggestive of DVT, right? Calf pain, especially unilateral leg edema in a patient who has not been previously had this problem. Think about that. Patients will tell toilet එකට යනකොට මේ doctor මගේ මේ කකුල පොඩ්ඩක් රිදුනා. හරිද? So think about that, right? Hemoptysis again, right? Why do we get hemoptysis in pulmonary embolism? When you have pulmonary embolism, there will be pulmonary infarction, and infarction will cause a hemorrhagic necrosis, and you can have hemoptysis, right? Heart rate, these patients will have tachycardia, right? Because the mechanical stimulation, such as sometimes hypoxemia, will cause tachycardia in these patients. Pain on deep venous thrombosis and unilateral edema. So the sum, depending on the score, will help you to say whether it's a high risk. So if the risk is high, the total aggregation is more than 11, right? Then we have to go directly for a CTPA, right? Sometimes even that is not needed. Clinically you might have to think about the diagnosis, right? And intermediate and low, you do the D-dimer. If it is high, you go for investigation and starting treatment. If it is negative D-dimer, very unlikely that the patient is having a pulmonary embolism. Okay, right? There's another score. We have the Wells score as well, the Geneva score. I selected the Geneva score because it has a good predictability than other scores. But you can use what we call the Wells score as well, which is commonly used in other groups, right? Right. So. Right. Acidosis, again, we have to think about, especially young patients coming with shortness of breath, acute renal failure. Sometimes it might be the first presentation of diabetic ketoacidosis. Patient, if he's unconscious, may be a case of poisoning. Deep, rapid deep breaths. Think about acidosis. Do ABG, right? After the initial assessment, do the ABG. Look at the pH, look at the bicarbonate. Then you will be able to identify that. And in these patients, lactate might also be high. Muscle weakness, Guillain-Barré syndrome can come silently. Organophosphate poisoning can be there, right? Okay, so we have to think about these possibilities in patients. Sudden hypokalemic, kalemic, that is low potassium, periodic paralysis can present like this, but usually they don't go into respiratory failure. So there are conditions that we have to think about muscle weakness. So in the appropriate setting, you might have to think. They might not show dyspnea. They will not show the rapid tachypnea. They will not show the deep breaths, right? But you have to think about muscle weakness, right? And always think before labeling the patient as anxious, that is the final diagnosis, or dysfunctional breathing disorder. Patient comes with shortness of breath, you name them as that, or anxiety, and refer the patient to a psychiatrist, right? Yes, that might be a cause as well. Sometimes they can have two things together. They can have asthma. They are, they feel anxious as well. So if you only treat for the anxiety, the patient's asthma will not go off. And then you might get a severe asthma patient in about 2 weeks' time or 1 month's time, right? But who is not anxious probably, right? So, but before labeling patient that is normal, always think whether something I'm missing. So I think this X-ray is clear to you. Do you find anything abnormal in this X-ray? Right. In a chest X-ray, I usually look at 3 or 4 areas before I say that the chest X-ray is normal. Obviously, if there's a pneumothorax, if there's a large pneumonia, pleural effusion, probably I will be able to see most likely. But what I usually see, there are several areas that I see. I see under the diaphragm usually, right? Before saying that this X-ray is normal, to see whether there is air under the diaphragm. Right? So if you see air under the diaphragm, if the patient has undergone a cesarean section 1 day back, that might be normal. But else, in abdominal pain patient with air under the diaphragm, that might indicate that the patient is having a perforated gastric ulcer, and that might be the cause of tachypnea because the patient has gone into sepsis because intra-abdominal sepsis, and not something wrong in the abdomen. So important thing is take a chest X-ray and look at the under the diaphragm. Looks normal. Then I look behind the heart, right? Sometimes when you have lower lobe collapse of the lung, you don't see any significant abnormalities. But if you see the sail sign behind the heart, or sometimes you might see a tumor behind the heart. So, or else if you don't see, we might miss them, right? The third area that I usually look for is the apex of the lung. Right? Apex of the lung is very, very, very crowded usually, isn't it? There are a lot of ribs, the clavicle comes in, the pleura is sometimes thickened, and you might not see any abnormality. But have a look at the apex clearly. Now here, these lung markings you can follow up to here. But if you look at these lung markings coming here, it abruptly ends here. And you can see this lung marking beautifully. Okay? So this is basically a apical pneumothorax. And if you send this patient home who comes with shortness of breath, he might present to you with a tension pneumothorax within the next few hours sometimes. Sometimes if he's lucky, this will absorb itself and go off. But don't give luck a chance, right? That is, if we want to give a luck a chance, then we should not be doctors. We should be practicing something like Dhammika Paniya rather than being doctors, right? So, but always be conscious about that. Always look at the apex. Always look at the apex. And another area that I look in respiratory patients is the supraclavicular fossa, right? Supraclavicular fossa. The reason is that if you see patients who have subcutaneous emphysema here, right? Subcutaneous emphysema here, that might indicate a pneumomediastinum, esophageal rupture or tracheitis causing pneumomediastinum, right? So sometimes I had a boy in Badulla when I worked in Badulla who came with shortness of breath and asthma with the X-ray showed pneumomediastinum. I identified it because of this superior, in the supraclavicular phase there was subcutaneous emphysema, right? So with that, I think I will end my presentation. I know that it took a little bit of more time, but I'm really happy that at least around 200 people are still there. I hope they are listening to the lecture, not watching anime or something like that. But hopefully, I think Professor Kudagammana and the council's request was basically to have this type of a chat with you, to have a free chat rather than constricting myself to the, to a certain area, and allow the flow to happen, so that I will be able to share with you my experiences as uh, a physician or respiratory physician or pulmonologist for the past few years. I still consider myself as a middle-aged man, picking up seashells in a seashore. When you think about the immense amount of knowledge that is there in the world, so I'm just a simple man trying to pick up the seashells. I can't say that I'm a child now. I'm a middle-aged man, so still there are a lot of things to learn. But the important thing as a medical doctor and budding students, that the one thing that I want you all to do is to never stop the urge to learn. Even at this age, even at this age, I try to improve myself. My colleagues, I know Duminda very well, he wants to improve ourselves. We daily read things, we look at the guidelines, we see what is happening, we learn from our patients still, right? So never stop learning. Medicine is a beautiful, beautiful field, right? If you like it, if you have to like it, you have to enjoy it, then definitely you will thoroughly be happy of what you do. Okay? At the end of the day, the most important thing in one's life, I think, is to be happy. There are, you get calls, you are frustrated due to some people, some doing some certain things. But at the end of the day, if you can be happy of what you do to our patients, like this man, right? And if you can make him smile, and if we can make him safe and send the patient home to their loving family, where 4 children will be depending on this man. If this man dies, their total, future will be at a risk. That is the best that medicine that has given to us, right? And I'm really thankful to our country, which taught us free. Even though I went to a private school until A levels, even the books were given free. But the books were given free. University education was free. My postgraduate education was free, right? Foreign training, I got a paid job, but even then they supported me for 1 or 2 months, right? So we have to serve our people. We have to serve the innocent people. And hopefully from Peradeniya, we can produce graduates who will serve the people of this country or this world to their best of their ability, so that you can have the correct skills. You need to have the correct skills. You need to have the correct knowledge. That is what we are trying to give it to you, right? Your teachers, the teachers in the faculty, you are fortunate to have, they are trying to give their best, even in their troubled times. In this troubled time, they are trying to give you the best that they can, right? Make use of it and learn. Make yourself knowledgeable. Read about certain things. Don't waste your time, right? And then hopefully you will become skilled and knowledgeable doctors. But those things are not important if you don't have the correct attitude. So have the correct attitude. Look at your patient as you will be looking at someone in your own family, because this one is someone's father, someone's husband, someone's brother. Okay, and thank you very much, Professor Kudagamana, for inviting me today and giving me the opportunity to deliver the first presentation. There were some technical aspects. I was really worried about it. This was not the presentation that I intended to do. There were some changes that I have did, but thank you very much for giving me the chance. And Duminda, thank you again for arranging this. Sisira, again, thank you for arranging this in a very, very short time. And hopefully this was useful. And I think I have gone beyond my time for the lecture. But if there are questions, I would be very happy to answer.
I think it was comprehensive, and I still we see more than any 1 or 2 questions. Probably we can accommodate that. Also, now later on, also we can send in their questions to you, Neranjan. I'm sure you will be able to answer them, right? With time.
There are a couple of questions, Neranjan. Hello, Neranjan, can you hear me? Hello, Neranjan.
Looks like there's some technical issues there, Dovinder.
Yeah. So there were few couple of. Shall I quickly answer these two questions, Tushar?
Yes, please do. Yeah.
Yeah. So I will be very brief. In COPD, we are giving 88 to 90% of oxygen. Could you please give exact reason? That was discussed in the lecture. But basically, these people are having a hypoxic drive. So now Neranjan explained earlier that. Neranjan, can you hear me? Hello.
No, I think you can proceed, Dovinder.
Yeah. So basically, usually people are having hypercapnic drive. So with the high carbon dioxide, their respiratory rate goes up. The oxygen, the respiratory center depends on carbon dioxide. But in COPD, there's a thing called carbon dioxide narcosis because of prolonged high carbon dioxide. So they are dependent on oxygen. So you do not want to overcorrect oxygen. So that's the reason.
Right. Thank you. One more question, I think.
Yeah, I can't hear you, Dovinder.
Yeah. Now, yeah. So we can see
Yeah,
you.
yeah, I can answer them. I can definitely answer them. Can you hear me? Can you hear me?
Yeah, Neranjan, the first question Dovinder answered, and
Can I antimatic
there's this can kyphoscoliosis cause type 2 respiratory failure? Umang is asking.
Yeah, Neranjan was there. Neranjan, are you here? Hello.
Hello, can you hear me?
Yeah, we can hear
I
you.
can't hear you, Dovinder.
Yes, Neranjan.
Dovinder, I can't
There's
hear
another
you.
question about BiPAP and CPAP. The difference between BiPAP and CPAP.
Yeah. Dominder, I'm sorry, I can't hear you, Dominder. Can the students hear me, please? Can you just tell me whether you can hear me?
Yes, we can hear.
Can you just send me a message to see whether you can hear me? Right. Yeah, you can hear me. So, right. So there are some, Dominda, I really can't hear you. So, yeah, can I answer these questions? So I don't know why you can't hear me. Maybe I can't hear Dr. Dominda. So there were about one or two questions about, yeah. Yeah, like one or two questions about BiPAP and CPAP. That's a very good question, right? I think, so I'll go from up and we have here you check here, right? So the reason for giving controlled oxygen to COPD, as I explained it previously, basically it was sent by Galaxy Tab. So basically, as I told you, in COPD, the carbon dioxide is retained in some of the patients, and because of the carbon dioxide is retained at the normal physiological level, their central chemoreceptor center is desensitized to the carbon dioxide, and the respiratory drive is not driven by carbon dioxide. The respiratory drive is driven by hypoxemia, and because of that, in these patients, if we try to overcorrect hypoxemia more than 92%, what happens is they will retain carbon dioxide more because the ventilation rate will go down rapidly because oxygen is corrected and there's nothing to drive the ventilation in this patient respiratory rate. Hence the carbon dioxide will go up. They can go into type 2 respiratory failure. Hence I think I think I have answered that question. So then you have to give controlled oxygen. The definition of controlled oxygen is that you know exactly how much oxygen is given to your patients, right? So there are many methods of giving oxygen. You have seen the nasal cannula, nasal prongs, right? And you have seen the Hudson's mask. You have seen the rebreathing mask, but it is basically not controlled oxygen. You can't actually define or know the amount of, you can, slightly know, you can gradually calculate the FiO2, the amount of oxygen concentration, but the ideal way of doing controlled oxygen is given by a Venturi device. You have seen these small devices in various colors, red, green, yellow, white, orange. So depending on the device, you fit it to a Hudson's mask, that's the normal mask, and you adjust the flow rate depending on the requirement that is mentioned in the Venturi device. So there is a Venturi device is there which will say how much percentage that will be delivered, that is 40% oxygen. But to deliver 40% oxygen through that Venturi device, you have to give adequate amount of flow rate. So at the same device, they will mention the amount of oxygen that is you have to have, or the flow rate of oxygen that you have to give. So for example, if the red says 40% and you need 15 liters of oxygen through it to get 40%, if you connect the red and if you give 10 liters of oxygen through the port, you will not get 40% FiO2. So the important thing, if you are giving a Venturi device, which should be the norm in patients with COPD, controlled oxygen, right? Other patients, if you don't mind, but controlled oxygen is that, then you have to correctly take the correct Venturi device and correctly set the flow rate appropriately, or else there will be no use of giving or controlled oxygen, right? And there's a beautiful question on BiPAP and CPAP. Right, so there is a little bit of confusion between these PAPs. Basically, now ventilation is, now in a normal person, it's a negative pressure ventilation. Why I'm saying normal person negative pressure ventilation? When you breathe in, remember, you take a breath in, but what happens first? This thoracic cavity is expanded, the diaphragm is pushed down, and the interthoracic cavity pressure will be negative. Right, this negative pressure is conducted into the airways, and the atmospheric pressure is higher than that, and air will go in, because from a positive to negative area. So that is actually a negative pressure when we breathe in. We tried to create a similar thing in the polio epidemic in the 1930s. If you look at the Google, look at iron lung, IRON-LUNG, type it and look at in the Google, you will see that people are put in large barrels like things where there will be a negative pressure created in the barrel so that the lungs are expanded, and obviously that created a huge amount of problem, even though we were able to save many lives. But later what we did was we decided there was some earlier interventions like that. We put pressure in from the mouth, right? So that is positive pressure. We are pushing air in rather than allowing lungs to expand and get in, suck in air. We are pushing air in. That is what we call positive airway pressure ventilation, right? Positive airway pressure. So I'm pushing air in, right? So if you put a tube into your trachea, then it's called non-invasive positive airway pressure. Invasive positive airway pressure ventilation. And when you put it in the nose, around the nose, and when you create a pressure here, right? In inspiration, you push in air. In inspiration, you push in air. That is called non-invasive ventilation or BiPAP. Why are we calling it BiPAP? Basically, here you are increasing the pressure in inspiration. For example, you are increasing the pressure in inspiration to water millimeters 15, right? But when you expire, if you keep that pressure here, what will happen? You can't expire against that resistance, isn't it? Because there's a huge pressure here, right? Because expiration is a passive process. So we bring down the pressure without getting it to zero up to a certain level, right? Which is called expiratory positive airway pressure, that EPAP, right? EPAP, right? So now when you are inspirating, you have a pressure that is called inspiratory positive airway pressure value, IPAP, okay? And when you are expiring, you create a pressure here that is an expiratory positive airway pressure, right? So you have two levels of pressure, two levels of positive airway pressure. So bi-level positive airway pressure, BiPAP. Understood? Okay, right. So then what we have is CPAP, that is called continuous positive airway pressure, which is actually not a part of non-invasive ventilation, because you don't ventilate in CPAP. What you do is you create a positive pressure that is the same in inspiration and expiration. So the positive pressure is the same in inspiration as well as in expiration, right? So if you keep that mask near your face, you will hear a continuous blow into your face. But if you look at the BiPAP, you will have two levels of pressure, high pressure low pressure. So the continuous positive airway pressure, the indications for use are different. It is used in what we call obstructive sleep apnea, the snoring people who need support to their ventilation. So when you have this positive airway pressure continuously happening, what will happen is this positive airway pressure will keep your pharynx open, so that you will have a patent airway during your sleep. That is one indication of CPAP, right? But you can't increase it up to after a certain level because expiration will be affected, right? And the other thing is you use CPAP or continuous positive airway pressure in heart failure, congestive cardiac failure, where you have, what happens is you increase the pressure in the airway, and because of that the alveolar pressure will be open, high, and you will be pushing out fluid into the, because in heart failure what happens, the lungs are flooded with fluid because the left ventricle is failed. So you will be pushing the airway to the vessels as much as possible until the furosemide and the GTN works, and at the same time it will help to keep the alveoli open rather than collapsed, right? So CPAP is indicated in congestive cardiac failure and obstructive sleep apnea. BiPAP is usually indicated in conditions in COPD like that, right? Hope, and in other respiratory failures like Duchenne muscular dystrophies, where you can't breathe, the muscles are not functioning, and motor neuron disease. Sometimes even in foreign countries, we send the patient with a bilevel ventilation home so that they can support their breathing, right? So that is what they do. So I hope that you can you understand the difference between the CPAP and the BiPAP. And thank you very much for asking that question. That indicates that you have read about it and you are interested about it. Thank you very much. So in COPD, we are giving 88 to 92% of oxygen. Could you please give the exact reason? I think I explained it to you. If it is not clear, please tell me, right? And how we decide on BiPAP and CPAP, again, depending on the underlying condition. If you have obstructive sleep apnea, ideally we go for a CPAP, but if you have obesity hyperventilation syndrome with obstructive sleep apnea with ventilation dysfunction, we might think about a BiPAP, right? When in the acute setup, what I usually go is, if it's a patient is having COPD with ventilator dysfunction, elevated carbon dioxide, the choice is BiPAP, right? But if we have cardiac failure, the choice is CPAP. But in cardiac failure, even you can use BiPAP. So, but you can't use CPAP, that is continuous positive airway pressure, in COPD exacerbations. That we have to remember. But you can use BiPAP in cardiac failure, right? So to keep this things simple, CPAP is used in cardiac failure usually. BiPAP is usually used in ventilatory failures like COPD, muscle dysfunction, and etc. Right. Kyphoscoliosis is a type 2 respiratory failure. Yes, it is a cause. As I said previously, it disrupts the ventilatory function. CPAP, BiPAP. Okay. So I think most of the questions are answered. Right. So
yeah, I think Neranjan, I think it's
so hopefully I think we can stop now.
Yeah. Dominda?
Yeah.
Hello. Yeah, I think there are, why noble carbon dioxide is lethal in asthma than COPD, to the exact reason that I explained you previously. In COPD, the patients are, they tolerate carbon dioxide, but in asthma, what happens is basically elevation of carbon dioxide in this otherwise normal lung is indicating that the patient is getting exhausted because of asthma, and the patient will go into respiratory arrest very quickly. So hopefully I answered that question. And I'm really sorry that there are some technical issues today, but I hope that all of you were able to hear this without any problem. I will be sending to everybody my email address now, right? So even though I might be a bit busy, but if you have any questions, right, or clarifications, I'm very happy to discuss with you at any forum. and I'm sure that the PEMSA will facilitate it as well. So thank you very much for your kind participation, and again thank you Professor Tushara Gudamambana, Duminda, Sisira, and everyone who facilitated this beautiful thing. Thank you very much.
Thank you, Neranjan. Duminda, over to you.
Yeah. Okay. Thank you, Neranjan. I don't think Neranjan can hear, so I will thank him personally.
Okay.
But Neranjan actually agreed to do this lecture at a very short notice. So, and it is a very clinically oriented and a very elaborated lecture.
Yeah.
We have a lot of clinical stuff, very basic stuff, which he made very interesting. So if you can hear, thank you, Ranjan. I will give him a call anyway. So thanks everyone for your patient listening. You have been has been a very long time, about more than 2 hours, and we had about more than 200 participants. So I think it's very encouraging. So I think we'll call it a day now. Then thank you. Thanks again for everyone.
Thank you, Duminda. Thank you, everybody. Okay, good night, everybody.
Night.